Hello everyone, my name is Captain Greener. I'm a 65 Delta. I am the OIC of the Louisville Healthcare Recruiting Center. And I'm here today to talk to you about the use of the SIM-Man and how you can use the SIM-Man to create events to drive interest in Army medicine. Now the most common events that are going on now that we do are suture labs. And suture labs are okay. It's an event that, it's a simulation that can bring your HPSBs in. However, it doesn't talk anything about Army medicine. So the conversation going into our scholarship and having our students start to think about actually putting on the uniform and joining the Army healthcare team is a little bit more artificial. So a preferred method is to actually use the equipment we have, show all the innovations that we're doing as part of the Army healthcare team, and actually have your, particularly probably your pre-med students, get in, get their hands dirty, use the pieces of equipment that our Army healthcare professionals use, and then that is an awesome tie-in to getting them to actually join the Army. So we have lots of pre-med groups out there, and they need events. So that's an opportunity for us to get in there and carry out these events and really capture that HPSB market. And actually your med students, even your first and second years, can utilize this information too. But I know there's a lot of barriers for a lot of you out there because you're not maybe a clinician, you've not used this equipment. But I have a lot of reasons to say that you can still do this even though you happen not to be a clinician yourself. So one of those reasons is the fact that in reality, in the civilian healthcare market, the people that actually teach the new equipment are not clinicians themselves. They're actually generally sales reps that come in. So the healthcare professionals are used to people that don't necessarily know the whole clinical piece to the equipment, but can show them how to actually effectively use it. The other thing to tell you is these are undergraduates. They don't have any medical experience at this point anyway. So you're coming in uniform, and you're going to come in with the knowledge that you're going to learn today, and you can watch this video over and over until you got it down so that you can go out and just show them some equipment. And they'll be happy to have this opportunity, and they're not going to ask you any hard questions. So that was the point of this video, is getting it taped so that you can go back and watch it and that you can actually utilize this SIM-Man. So originally when we got the SIM-Man, it just came with the SIM-Man itself. It didn't come with any equipment. So we have a very expensive piece of equipment that we can use, but we weren't having the ability to actually demonstrate anything with it. So for purposes of recording this, in case you're watching this video and you don't have this equipment, the way that we figured out a way to be able to get some equipment is we use the North American Rescue, and all the equipment that you see here displayed today is from North American Rescue. So our Battalion XO actually purchased this equipment. So if you have a SIM-Man but you don't have this equipment, that's the solution that we found previously. So you can actually use this SIM-Man as a static display at a table event. And the nice thing is about having this at your table is it's not another lollipop, it's not another raffle. It's something really big and very different, and it's going to draw a lot of attention to your market. So the SIM-Man is actually driven through the tablet here. If you haven't downloaded the SmartStat app to the tablet that's connected to your SIM-Man, you need to connect to your MiFi and download the SmartStat app. You can power it two different ways. There's a power cord. My favorite way to do it is use DC power and connect it through this cord that's next to the leg. You can actually also charge up the leg, and the leg is a battery and it will last for several hours. So it would be good of you to connect the mannequin to the tablet, because this is how you control it, and you can show your people coming by many things to kind of spur them to come to your table, and then you can talk to them about whatever program you want to talk to them about. You actually connect your tablet to the Wi-Fi that's in the SIM-Man, his Wi-Fi, his simulations with a number, and then you connect it. The password is simulations01. So then you go into the app, the SmartStat app. You go to the gear button, and then you find the SIM-Man, and then you actually push the button. You just tap the button. You don't slide it like you want to. Once you get a control of it, then you can show many things. You can have his fingers light up. You can adjust his breathing sounds, his respirations and things. It's not really a feature that I use very often, but if you're using it as just a table display, that's an option for you. So when I talk about doing classes, I generally teach the TC3 standard, the Tactical Combat Casualty Care standard. There's 4 preventable causes of death. It leads to 4 classes that you can teach. The first one is probably the most preferred, and if you're just getting started, that's what I would recommend, is that you teach the hemorrhage class. Since I've been teaching the hemorrhage class, something came out called the Stop the Bleed campaign. This is a big national campaign, and it's the way I teach the hemorrhage control class now. So what happened is, after a mass shooting, that the White House got together and created an initiative to study what happened and what went wrong during the mass shooting. And what they found is many people died of wounds that could have been prevented if just people knew how to stop the bleed. The reality is when you're talking about a mass shooting, the scene is unsafe. So the security forces have to come in and make the scene safe before the emergency medical personnel can attend to the emergency. Well, during that crucial time, several students bled to death. So the White House took that knowledge and they tasked the American College of Surgeons Committee on Trauma to create a solution. What they did is they took a look at the military standard, the Tactical Combat Casualty Care, and created a program to go out and teach the layperson how to stop the bleed. So that's why this class was created, and this is why it's such a great class for us to teach as being in the military, is we're basically teaching the military standard with a civilian platform. The other reality is if you become a Stop the Bleed instructor, which after everybody goes through the class, they get a certificate, which you can give out to everybody who attends the event. And what you tell them is at the end of the training that they'll be getting their certificate via email. So now what you've created is you've created a reason for them to read your email. They're looking forward to your email, and guess what you're going to do in that email? You're going to put your messaging in there so that you know they're actually going to read it because they're looking forward to their email. And every time I've done this event, people are very excited about getting the certificate because it actually is signed by the American College of Surgeons. Actually what you can do is you can post the event online, and actually every time I've held the event, I've had people from the outside call me because they saw it on the website, and I've always had some outside people coming to my events, which is great because you want to reach as broad of a market as possible. So, and the other thing I can say is once you got your certificate, those of you that are recruiters, obviously we're all in the military, you can go on stopthebleed.org and register to be an instructor yourself so that you can go out and teach these classes. So that is the format that I use to teach the Stop the Bleed class. The Stop the Bleed class talks about how to stop the bleed without any equipment, and it also talks about some of the special equipment that we use in the military. The first category of hemorrhage, the first category of injuries that we take a look at, and the most common cause of preventable death in the subset of hemorrhage itself is wounds to the extremities. So when we talk about extremity wounds, we have more options available to us. So the Army created the tourniquet, and a big part of the Stop the Bleed class is the use of the tourniquet. The preferred tourniquet per the American College of Surgeons is actually the combat application tourniquet. So this tourniquet was created by just one of our medics who created this life-saving device, and it now is the standard throughout the world as far as hemorrhage control. So an important piece about the Stop the Bleed class is actually teaching the proper use of the tourniquets. The PowerPoint that you're given when you're teaching this class can walk you through step by step how to utilize the tourniquets. I'm not going to go through that. I'm sure we're all aware of the use of tourniquets. I will teach you though some fine points about the tourniquet itself. This is the friction adapter. This is the windlass clip, the windlass strap, and your hook and loop. So when you teach this class, you actually after you show everyone the use of the tourniquet, you give out the tourniquet and they all take a look at it and hold it and get to understand it. You actually invite everyone up and they have to do a check-off. So some fine points about applying a tourniquet, just so you will be successful. You cannot apply a tourniquet on a joint. So if the injury is near the joint, you have to go 2 centimeters above the joint. The other piece to know, it's generally better to tighten the tourniquet towards you rather than trying to tighten it away from you. So that's an important piece that everyone pretty much messes up when they're first learning how to apply it. So just for ease of illustration, we'll just assume that we have an injury down here. So when we're applying the tourniquet, like I said, you're tightening it towards you. And the other thing to know is this friction adapter, if you start it too close to you, when you start to tighten it, it'll start to sneak around and get stuck. So it's very important for you to apply this tourniquet up high so that when you go to tighten, and I really encourage when I'm teaching that people apply all their weight into it and get it as tight as possible. And that's a piece that people also don't necessarily do right the first time they're trying this. And then after you get it tight, you start to engage that hook and loop so that it doesn't start to loosen. So people want to jump into the windlass when they're first learning, so making sure that you're teaching them to engage that hook and loop so it doesn't become loose before they start turning the windlass device. So then you just have them tighten the windlass as much as they can to be able to make sure, and then the way you check is to make sure that it is as tight as possible. So you can just, at this point, put the strap through the windlass clip and tie it off. But a way to make it a little bit nicer, because this loose tag can come loose, it can pull on things, and obviously we don't want that to come loose. You can actually wrap the strap around the windlass device, and that way you have less tag. Studies have shown if the tourniquet is applied for less than 2 hours, your casualty will not lose its limb. There's not been any cases of that. It's important to know the time, and there is a spot that you can write the time so that when the emergency medical people come in, they know how long the tourniquet's been on, because that will affect the care. The other thing to talk about is if one tourniquet is not enough, you can apply a second tourniquet right next to the first tourniquet. Now, obviously, there's not enough times where the tourniquet is available. So the class also talks about how do we stop the bleed when you don't have a tourniquet. The hope is the Stop the Bleed campaign will lead to tourniquets being available in a Stop the Bleed kit, just like we have AEDs in public areas. However, we don't all walk around with tourniquets at all times. So to be able to stop a bleed, one way is just applying direct pressure. Particularly if the wound is shallow, direct pressure can be the solution. The problem is it's not a magical solution, so just covering up the wound is not enough. It's not going to stop the bleed. You can kind of think of, there's the wound, now I don't see it, so because I can't see it, it's taken care of. Well, that's not really proper. So the other piece to know is putting all your weight into it to stop the bleed. If we're talking about life-threatening bleeding, we're talking about spurting blood, we're talking about blood soaking extremities. We have to overcome that significant pressure that's causing that bleed. So the point of the Stop the Bleed class is to teach you to use two hands and get your shoulders over it. Now, this is a tiring exercise, so you may need to have somebody relieve you when possible if you're doing this. But you never want to release the pressure once you start the pressure, because that clot that's forming, that's going to save that person's life, is very fragile. And you release to check to see if you stop the bleeding or not. That clot can break off, and perhaps you won't be able to get them to clot again. So it's very important that you apply continuous pressure. So that can be applied. In every situation. We all have extra clothes that we can use to stand in for this cravat that we're using. The other piece is not part of the Stop the Bleed class, but you can have somebody applied pressure above the joint to occlude that major artery as well to help assist in that bleeding stopping in the beginning. So the Army has been very successful with the use of tourniquets. We've never had survival rates that we've had since we've had the tourniquets available. So the next thing that we started to look at is junctional bleeding. So junctional bleeding, this inguinal area here and the axillary region here, obviously we cannot apply a tourniquet. Obviously we can't apply a tourniquet on a neck more than once. So we have to think about how we're going to stop the bleed in those instances. The other thing to tell you is if there's cavitation of the wounds, we need to address that. So if I have this big laceration here, I need to actually put something in there to stop the bleeding, because if I apply pressure over that cavity, it's not actually doing what we need to do, which is to get pressure over that major vessel. So this is another good plug for the Army. The Stop the Bleed kit talks about the use of combat gauze. There's many similar products to to combat gauze, but the bottom line is this material is gauze impregnated with chitin. Chitin is a seashell. And the reason for that is that seashell, when it interacts with blood, it stimulates the coagulation cascade. Ultimately, what I'm trying to say is it's helping with the clotting process is what we're trying to do. So combat gauze is preferred. The hope is we can get this combat gauze and these tourniquets out there in the community. But outside of that, you can use regular gauze, or again, if you don't have the combat gauze, you can just use any type of dressing that you have available. So the important piece of this is not part of the class, but is an important piece that I think that I teach, is you actually have to identify where the bleeding is. So it's not enough just to shove a bunch of dressing in there. Now, if I was injured and somebody did this for me, that's great, that's something, but what I want to take it to the next level, and the point is to actually identify that source of bleeding. Once you may need to scoop some of the blood out of the way. If you have gloves, obviously gloves are preferred in this time. However, if you don't have gloves available, you just let the emergency medical personnel that are responding to the event know that you were exposed to a bloodborne pathogen, and they'll take care of you. So identify that source of bleeding, that source of the start of the river, and I apply direct pressure over top that source. And I'm constantly maintaining, that's why I'm using my 2 fingers. So when one finger is bringing more dressing, the other one is taking over. So I'm constantly applying pressure right at the exact site. So when we talk about cavities, we actually have to take a look at where that source is. If you just throw a bunch of gauze in there, it might go into a blind cavity where the source of the bleeding isn't at. So you identify it, and then you can apply your direct pressure over top of that wound. So this works for wounds that are deep. It also works for those junctional wounds of the neck, armpit, and in the groin area. So as far as the Stop the Bleed class goes, if we were actually doing the Stop the Bleed class, this would be the point where you divide everybody up. They would get their hands dirty, and they would actually use the combat gauze. So the other piece that I stress during the class, not really necessarily part of the Stop the Bleed class, but important piece, is to actually expose the person to identify all the wounds. Any member that's responding to an event that has been part of your Stop the Bleed class are probably the most trained people that are there. So they might direct people to stop the bleed, show them how to do it, but that person who's trained needs to go and take a look at the rest of the body to make sure there's not other sources of bleeding. Because the reality is when we're exposed to an event like this, our heartbeat starts going, we get that sympathetic overload, and we focus in on one injury and we miss something. So making sure that we're exposing the person to find all the wounds, because we might not be treating the life-threatening bleeding. That is basically the hemorrhage class, and I'm confident that all of you can go out there and be successful in teaching the Stop the Bleed class. So those of you that are watching this video that didn't participate in this, I would ask the people in your formation who's Stop the Bleed trained so that you can become trained, you can become an instructor yourself, and then you can go out and teach this class. And I'll tell you, when you start offering this class, you're going to have a lot of people that are interested. You're going to have a great attendance. I've had full attendance during some of my pre-med groups, and it's awesome lead-in because you're sending that email later, and you can talk about the Stop the Bleed class. Now, in the RCMAT, the hemorrhage control training kit, that's what I've demonstrated today. This is included in there. You don't even actually need the SimMan to be able to demonstrate. You could use the tourniquet on this as well. So actually all you really need is the tourniquet, some gauze, preferably some combat gauze, and then you're good to be able to demonstrate this class. So as you can see, a very simple class. We all know this as soldiers. We've all been trained on the use of tourniquets. It's definitely something that's in our wheelhouse. So I would recommend that you start with this class, and then as you feel comfortable getting in front of groups of recipients, if you want to broaden it out, then we start talking about our next 3 classes. So the next most common preventable cause of death is airway obstruction. So the easiest way to treat an airway obstruction is head tilt chin lift. The head tilt chin lift method. So that's super quick, and you can't really make a class about that. And also if they have a neck injury, the jaw thrust method to open up the airway. It's important to talk about that, but the airway obstruction class goes into much more. So suction is always difficult to get in the field because the equipment is big. This is a nice portable device to be able to look at any secretions that are in the back of the throat, and you can quickly remove those secretions, a quick, easy solution for you. in the case of airway obstructions. We also have these two devices here, oral pharyngeal airway. You insert it by starting to put it inside the mouth like this, and then you twist to be able to insert it. So the disadvantage of an oral pharyngeal airway is, now the mannequins don't always necessarily react naturally, but the disadvantage is if they're conscious, they have a gag reflex. Also, if they're unconscious and they become conscious, they regain their gag reflex. So this is going to cause an issue. So it's not the preferred way, but it is a way to maintain some patency. So that's oral pharyngeal airway. This is a nasal pharyngeal airway. So you take a look at the bevel edge, take a look at the nares are the nostrils. The septum is the piece of tissue between the two nostrils. You basically make a pig nose, and in a trauma situation, you might not have access to lubrication, but there's secretion somewhere that you can use to lubricate, or you can use the water-based jelly, and you just insert this nasopharyngeal airway. So this is not indicated in the case of a skull fracture because this tube can actually penetrate that, and a tube in the brain is not good. So now you have a way to maintain an airway. And let's see if I have it in the back of the throat. So there I go, nasopharyngeal airway. The nice thing is, if they regain consciousness, they're uncomfortable because they have something in their nose, but it's not stimulating the gag reflex. So two simple and quick airways. Now, the King LT is the latest blind intubation technique that we have available to us. The great thing about a King LT is a person who doesn't have a lot of training can insert this to be able to establish an airway. What happens is these two balloons, when you put it into the back of the throat, that pharyngeal cavity, you inflate this balloon, and this balloon will anchor the device where it needs to be, and actually you'll ventilate here, and you know the air is going to go into the trachea and not into the esophagus. So when you direct intubate somebody, it is a difficult skill, and one we'll talk about, but the great thing about the King LT is that you inflate your balloon. And I should probably talk about the Luer lock system. So to be able to engage this syringe, the technique that you use is you inflate it and you twist it onto the device, and then you can add the air. And then when you're ready to take out the air, you do the opposite. So when I'm ready to extubate or remove the device, because I'm not sure how much air I put in there, I'll do it twice just to make sure I'm not trying to pull it out with air in the tube. I can go ahead and pull the tube out. And actually on the tube itself, it will tell you how much air to put in. So it says 60 to 80 milliliters on the King LT. So this is used very commonly by emergency medical personnel. And it is a cool thing that you can show your HPSP interest. So the next skill requires some practice to directly intubate someone. And I should mention, I brought my bagged valve mask over here, but that is a skill that you can cover too. It is really covered by BLS. You can provide oxygen to the lungs through a bag valve mask system, and these interventions are not as big of a priority as they seem to be on the different medical TV shows that are out there. So this is this is direct laryngoscopy. So I actually have a close hanger in there to play the role of the bougie, which basically is to provide stability to your tube. And the intubation device I have is a little variation of the one that you commonly see used, but this is a field application version. So the way you turn the light on this version, you just twist this. The other ones that people are more commonly used to are engaged and turned on by when you put in your blade into the device, it engages the light system. So the basic principles are all the same. Now this mannequin features some breakout teeth up here, and actually his teeth have already broken off in the back of his throat right now. But the reason that these teeth are breakable is so that when you try to intubate somebody, the whole purpose of this device here is so that you can visualize the vocal cords. Well, when you go to try to do this initially, the temptation is to want to rock back to get leverage. But when you rock back on a real person, you're rocking back on teeth and you're breaking teeth. So actually, the purpose of this is to, you just slide it underneath the tongue, and then there's a little triangle of tissue that you guys can kind of practice a little bit on your own if you want. And it's to be able to trick the trachea, which is kind of hidden up in there, to be able to come into a view. So I can actually visualize the vocal cords, and it's very important that I visualize the tube passing through the vocal cords. The other thing is you have to be quick with this, because when you're trying to put this tube down their throat, they're not breathing. So you'll pre-oxygenate them. And I'm moving fast so that I can show you guys all these classes all at once. So I visualize the tube going into the vocal cords and sliding back down into the trachea. So it is a difficult skill to master. Once I have it down, I inflate this balloon and it's anchored in place. I can take out my bougie. So it's a fun skill to practice. It takes a long time to actually master that skill. That's why we have these other interventions that are available to us. And it's a little bit more tricky to do on a mannequin itself. So then the next skill that we can talk about, something that's used more commonly in the military setting. So we've really innovated its use, particularly in the case when you have massive facial trauma, is the the crike, or the cricotomy. So if everybody can feel on their necks here, you have this thyroid cartilage, the big piece of the Adam's apple. Underneath here, there's a little a weakness here. There's a little place where the cricothyroid cartilage is. That's the place you actually want to puncture when you're doing a crike. So the kit is really nice and it's very small. So if you fail to intubate somebody, the traditional method, you can use this as the next solution. Or if they have massive facial trauma, then you can't intubate a person. This can be the solution as well. So what I like to do is always lay my equipment out based on what I'm going to use first, second, and third, just so that I know I'll be successful. So I got a little bit of air in my tube here. So the first device you use is scalpel. So this scalpel has a little clip on it here. So you're actually, when you're going to cut, you're going to make a vertical incision right over that cricothyroid cartilage. And then what happens is when you make that incision, the skin will naturally start to flare out because it's under some tension. So you make an initial vertical incision, and then what you do is you twist the scalpel 90 degrees, and then you puncture into the trachea. So I feel for that weakness here. I make my vertical incision, then I twist 90 degrees. I puncture into that space. So now I have the space secured with a scalpel. If I would remove the scalpel, tissue will move, blood has started, and I won't be able to find the right spot. So this is called a trach hook. The purpose of the trach hook is to secure that space so I can remove my scalpel. And again, with these skills, you're not teaching them to master the skill. You're just making them familiar with it, so that they have you're going to have the advantage of being the first person that has taught them how to do something, which is really neat. They're always going to remember you. So then the next step is to insert your tube. And then you inflate your balloon to anchor it into place. And then there's a little plastic, it's another version of the bougie that you can apply, and then you can use your bag valve mask minus the mask to be able to intubate them. And actually comes with, this can wrap around their neck and hold the trachea in place. So there I have established my airway. So it's something that's a lot of fun to be able to go out and and teach. You always see in the movies that they basically do this with a, with a pen. But this kit is small, nice and easy and portable. Now the civilian versions of this are quite large, but we've adapted to be able to carry all this. So those are the airway issues. So next, the third most common cause of preventable death are breathing. So when we talk about any violation to the pleural cavity, we all know that the pleural cavity is a vacuum. So if we violate that vacuum, it causes problems. So if you apply a dressing to a wound to the pleural cavity, anything from the Adam's apple to the umbilicus or the belly button, then we need to put something that's impermeable, or so that air does not get exchanged. So this is a chest seal that has been gummied up a little bit through being used previously. So a chest seal, if we see any types of wounds there, we actually remove the clear plastic piece and I'm going to apply this. Now I'm not going to apply it to my dummy because I don't want them to be super sticky. It actually comes with a piece of cloth that you can use to clean the site, and then you can apply this. So fortunately, there's not a good solution for teaching your students how to do this unless you want to spend quite a lot of time afterwards applying the gumminess. But it's an important concept to teach. So one of my soldiers, not one of my medics, but just one of my regular soldiers, responded to a motor vehicle accident. He treated for shock by applying a blanket over the person, and what happened was the victim developed respiratory distress. So he actually took a pen, shoved it into that pleural cavity to help equalize out that pressure. So just another example of soldiers doing amazing things. The more advanced technique for needle chest decompression, instead of using a pen, is actually using this device here, which is a 3.25 inch 16 or 14 gauge needle, quite an impressive needle. So the proper location, the indication for this is they're developed increasing respiratory distress in the setting of trauma. Likely, we talk about a sucking chest wound. So what you do is you find your clavicle, your clavicle bone. You find the middle of it, and then you walk your fingers down. So go ahead and walk. Touch your clavicles. So I get my students to do this too. Find the middle point of the clavicle, then walk your finger down. That first space is the first interclavicular space. Move down into the second one. So we're talking about the second space between the next set of ribs. That is your destination. That's your goal of where you want to insert this. Now the dummy is not exactly the right landmark, but you still can find the midclavicular line and pretend like you're walking down 2 steps. But I'm actually going to go right here because that's how the dummy's set up. So it's fine to teach them to just puncture this in, but actually what you want to do, a finer point is after the catheter, which is just another term for a hollow tube, does not get inserted. And of course, you're never supposed to do what I'm doing in real life, but just for purpose of demonstration. So you puncture through the tissue, and then as you puncture through the tissue, you can start to withdraw that needle, because you don't necessarily want that needle to go 3.5 inches down into the pleural cavity. So as you're able to use the needle as your driver, you can start removing the needle, and you're left with the catheter in. So I can't actually insert this all the way because there's not enough space in there to allow for that, but you can kind of give them the ability to at least start to insert the needle itself. So then what you're left with is this hub sticking out of this person, and you can actually apply a second one if needed to be able to help equalize that pressure. Now the definitive treatment is a chest tube, but this dummy doesn't lend itself very well to teaching the chest tube, so that's not something that I demonstrate. It actually has the incision here where the chest tube could go, but it doesn't have any depth to it, so you can't really teach that piece. But you can teach needle chest decompression, which is a fun thing. So that's a quicker class. You can actually, okay, so the fourth cause of preventable death is circulation. So You can actually do IVs on your dummies. I prefer not to, just because you'd be sticking them a whole bunch. So I generally use IV arms from the local medical school if I'm doing an IV lab. Obviously in the Army we stick each other, but I don't think I would encourage you to do a class where you're having students stick themselves, just because of the implications. So I do like to show this device, and the nice thing about this is more military specific. This is called the Talon. So some of you are familiar with a Fast 1. This is an adaptation of the Fast 1, and let me grab a syringe for this. So the Fast 1 is a big red tube that you can establish sternal access. Now the reason that interosseous access versus IV is intravenous, IO is interosseous or bone. The reason that interosseous is great is because in some trauma patients you cannot gain access. If someone's in shock, they're shunting their blood towards their central system, so that it's very difficult to find an access. So you can use an interosseous access in the tibia region, but again, if you're shunting, if you put drugs into a leg and the blood has already been shunted centrally to maintain perfusion or oxygenation of the brain, applying drugs here is not going to help you. The great thing about using a sternal access is this is already central, so fluids and drugs and things that we apply here are actually going to get to the system or be distributed through the limited blood supply and come centrally. So it's a really great site. The problem with the sternum, it's a very long and flat bone, so you can't just use your normal interosseous device, drill into the bone, because you might actually drill all the way through the bone. And obviously putting a needle through the breastbone or sternum is not a good thing. So this device here is a great innovation that we've developed in the United States Army to be able to do an interosseous of the sternum. So as you can see, there's several needles. This is a wicked device that you would not want to do in a training situation. But the purpose for these needles is to stabilize the device itself so that you can do the interosseous piece. So you would insert this, and there's a picture here of the sternal notch. When you look at your sternum, the top of your breastbone, there's a little notch here which you can feel. That's your landmark for the placement of this. So you will push this down hard, and I'm only gonna simulate that piece so that I don't put a whole bunch of needles through my mannequin. But then now that I have the stabilizing device, I can feel confident that I can apply this interosseous device into the sternum. So it is a twisting motion. You'll feel a little puncture as you get through that first layer of bone when you get into the cavity of the bone, and then you can take your needle and put it in your sharps container, which I don't have one available for me right now. So I'll just set it aside. Then I take my little tube here, preferably if it's filled with saline, but just for purposes of a quick demonstration. And again, I have a lure lock system to engage a lure lock. So this would be a stand-in for something that already has fluid in it. In this case, I'll pretend that it has fluid by using air. And that you engage the lure lock system with a twisting motion, and that opens up the tubing so that I can go ahead and administer some fluid, preferably lidocaine, to numb it because it's going to hurt a little bit. And now I have an access that's central, very easy to obtain, and no matter what my situation, this can be at least one of my accesses. And generally in trauma we want to have two, so this can be one answer to the problem. So this is something actually the military has really developed, and it is the standard is coming to civilian medicine too. So what we are selling is Army medicine, so we should be selling innovations that we're doing and let our potential HPSPs or anyone who's interested in Army medicine know that they're being part of a team that's constantly developing, constantly innovating because of the need. So what we are selling is a part of this healthcare team. So, so these are fun things to do. Also to drive that interest, develop relationships with your HPSP students. and then ultimately, the hope is that they're going to want to be part of this awesome team. So, and then we, along with the circulation is treating for shock. So I don't like to open up my blizzard blanket because it turns huge really quickly. But just for purpose of illustration, I'll show them a blizzard blanket that we use. And this ready heat, those of us in the Army know that this is basically like a giant MRE, or giant MRE pad that once you open this, expose it to air, it warms up. And then this is, we wrap them up in this blizzard blanket, and they're ready to ship out. So that's the final piece of my classes. So again, this is a lot of information in a small amount of time. The reason that this is videotaped is so that you can watch this at your leisure. You can play around with the mannequin. You don't have to be perfect at this. Just bring your mannequin out, do the events, start with the Stop the Bleed class, gain some comfort. And even if you, after this class, you are convinced that you can't do this, I would say when you're bringing an SME along to do these types of things, it's good if you have some comfort with this information so that you can be an assistant to that SME. So that when you go to recruit that person, you're not just the recruiter that's only there to recruit that person. You're somebody that's there to help with the class, and you can use that type of perspective to be able to be more successful in your recruiting operations. So I hope you enjoyed this class, and I hope you find it value, and I hope that you take this information and run with it and use it to be successful in the future.